Hi, my name is Laura Esfeller. I'm a patient advocate with Kidney Cancer Association. I'm here today with Dr. Precious Opurum from the University of Utah. And Dr. Opurum, if you can share with us a little bit about your study and how it relates to what we're talking about today at IKCS.
Wow. Thanks, Laura. So yes, I'm Precious. I'm from the University of Utah, and I work with Dr. Alejandro Sanchez and Katsuhiko Funai. Our work for today, this poster is basically on clear cell renal cell carcinoma, which is a very lethal disease. So in the world of kidney cancer, this is the most common one that is also metabolically active. And right now, the 5-year survival rate for patients with this is 14%, which we can tell is like very low, because 14 individuals out of 100 people are alive after 5 years, which is something we technically see that we have to do better on in terms of the research in this area. And obesity happens to be the #1 risk factor for clear cell renal cell carcinoma, but we don't understand how the mechanisms or how it associates to clear cell. So in my lab, we study mitochondria. Mitochondria is the powerhouse of your body that makes the ATP, the energy that you need to work. So after eating, your body metabolizes the substrates and the nutrients to make energy. And so mitochondria is that organelle in the body, so in the cell, that is responsible for doing that. So, however, we've seen that as a common feature in cancer cells, but and it influences, of course, energy metabolism and cell survival. Cancer cells are definitely, they are like metabolizing in a faster rate so that they can multiply and spread, and so mitochondria, they need energy for that. So in this case, mitochondria, we don't know how nobody has studied how it associates with renal cell carcinoma, and so my study is basically looking at this disease in the context of mitochondrial bioenergetics, like how does this cancer metabolize or get ATP, or how does this tumor environment causes this. And so in my lab, in terms of the mitochondria here, we have like little fences around the mitochondria, and so those fences are made up of lipids that we all know as fats. And so the different compositions of these fats in that making up the fence can affect how the mitochondria functions. So basically, if you remove some of those fats and replace them with other ones that are not supposed to be there, it might make the mitochondria not be able to make the ATP that is needed. So in this study here, we took patients with CCRCC, so they are undergoing surgery, so we are removing some part of their either the whole or partial part of their kidneys. And so when we remove those, we have the healthy portion and the tumor portion. So what I do is to take fresh tumor sample, and also from the other parts that has not been inflamed yet, I take samples from there also. And then when we did that, we decided to stratify the patients on obese and non-normal versus overweight, because here again we are looking at how obesity affects mitochondrial function. So here, when we classify them into two different patients, two different groups, the normal plus overweight and then the obese group. We also did, of course, the mitochondria assays. There are certain assays we do in the lab to determine whether the mitochondria is functioning well or whether it's defective. And so we also view those mitochondria in a microscope to see how the structure is, because again, like I explained, those lipid fences make up the structure of the mitochondria. We want to be able to see if it's broken down, if it's still with the normal structure. So here is just showing more of the clinical characteristics of these. Of course, I mentioned that the clear cell is the most ones that we see in the hospital. So of course we have more clear cell renal cell carcinoma. And then when I took the normal and the fresh tumor, and I did mitochondria assay, basically just giving them food like we'll give them food and see how the mitochondria metabolizes this. We did see that for sure the tumor samples, of course, had lower mitochondrial function, means they are not metabolizing those substrates well, and they had lower ATP production like we'd expect. And this is like to show a proof of concept of what is happening. And this actually assures our patients that indeed the doctors are making the right call by removing that portion so that it doesn't, affect the normal portion. So here is where I looked into the microscope to see their structure. We did see that the normal sample has the normal mitochondria fence, but in the tumor, the mitochondria have become smaller or more deformed, which again supports this data that indeed the tumor microenvironment is lower. So here we're talking about those little lipids that make up the fences of the mitochondria, and we see that when we look at the tumor and the normal, they have different types of lipids that make up this membrane. So like I mentioned, different types of lipids making up the membrane will determine whether the mitochondria is going to function well or not. And we did see, of course, there are some lipids that are upregulated, it means increased in the tumor microenvironment than in the sample, which again, since we are comparing normal and tumor, it means that there's really a dysregulation happening, or metabolic reprogramming, like we call it in the lab. So here is when I categorize the normal tissues, the tumor tissues alone. So we've already indicated that the normal and the tumor had lower than the normal, so that has been established. But in this case, we are comparing the tumor portions, like the inflamed portions of obese and non-obese samples, and we did see that the obese samples had way lower respiration and ATP production than the normal patients. So it means the normal patients in this case, we are categorizing using BMI of the normal will be like greater than 18.5 to 29. And then the obese will be greater than 30 of the BMI, which is the body mass index. So the obese people their tumor had lesser ability to metabolize the substrates that we give them. So this our finding is showing that, of course, the obese people, we see that the tumor and the normal, the tumor is less than the normal, which is established, but now it's showing the obesity goes further to actually lessen the ability for the mitochondria to do this work. So here we talk about, like my lab also studies physical inactivity, so we talk about how you should be more physically active, eat more diets, like we heard from the speakers who have spoken today, and I think this research is really important to really now understand. So this is just the tip of the iceberg of what we are doing. We are still going into further to do more work to understand how that mitochondrial function is happening in these two environments. Yeah.
Thank you for that. That's super interesting and fascinating work. And so I think to one of your last points, I think one of the takeaways for patients and providers, and please feel free to add to this, is that we know that there's a link between obesity and kidney cancer, and so I think that what do we do? What do we do to help patients, reduce their risk, or once they've been diagnosed, to manage their weight appropriately?
Yeah. So in this case, how to manage the weight, the way. So looking at the fact that obesity does have an effect on this mitochondria part, we can't say the whole picture for now because this is just the first part we've done in this research. But just looking into big picture, of course, patients, people should, in terms of chronic, kidney cancer, and even I also study chronic kidney disease, and we see that there's a link in terms of like obesity having a link in those two. And what we proclaim is that the people generally, we should all like eat healthy and also exercise. And exercising doesn't have to be you going to the gym and burning the whole fat. That's what some people are terrified by that, but it could be even you taking walks in your home, 5 minutes walk, relaxing. Those parts of exercise can even help help your body function better in terms of mitochondria functioning better. So that is what I'm going to say for now. And of course, patients always have to talk to their doctors and tell them, and because the doctors have the best advice for them in terms of what other things they are going through aside having clear cell renal cells. So that's something I would think would chip in. Of course, we all say exercise and eat well, eat more vegetables, you can eat all the fun things you want to eat, but moderation is the key in things like this, not really totally removing it from your diet, but you start small.
Right. Do you think that the rise of GLP-1s is going to impact this type of research in the future, or?
Oh, yeah, GLP-1. So yeah, that's an amazing question you asked, because my lab also studies, it's a mitochondria muscle lab. So we have been studying GLP-1s like semaglutide in terms of how these affect muscle. So we've seen in some cases that there's a healthy losing weight and there's a non-healthy losing weight. So the non-healthy losing weight is when you start losing muscle and all that. So we are doing those research now to see how that, because GLP-1s are rising, and we've been seeing that it's also implicated in something that can cure certain types of kidney diseases. But we have to study more around that in terms of like, it's not just losing weight. What type of weight are you losing? Are you losing the healthy weight, or are you losing muscle? Because those will now play differently in seeing the effect of GLP-1. So while I'll be studying that, and I don't know much about the results yet, but we are hoping that we're able to get more, more things to be able to add to this research on how GLP-1s can, be something that can be used in this setting.
Fantastic. Well, we'll be waiting anxiously for the results. Thank you so much for your time, and thank you for sharing more about your research with our audience.